Hello, friends. A warm welcome to another episode of 4D Details, Discussion, and Dialogue in Indian Diabetics. Today, we'll be talking with our experts on obesity as the root of all evil, the metabolic link to heart, kidney, and endocrine disorders. And we know obesity is the big elephant in the room, metaphorically speaking. It is considered the forerunner of a lot of chronic diseases. And now we are debating whether it should be itself labeled a disease. Rather, the debate is almost over, and we do believe that we have to consider it as a disease in its own right. So to have this discussion today, we have three experts with us, renowned experts. All three are from Kalburgi. Dr. Shankar Gowda B. Hosagodra. He is a DM cardiologist, works at Navodaya Hospital in Kalburgi. Warm welcome, Dr. Shankar Gowda. Along with him, we also have Dr. Santosh N. Harkure. He is a DNB endocrinology, again from Navodaya Hospital, Kalburgi. A warm welcome, Dr. Santosh. And our third expert is Dr. Purnima Takkal, DNB nephrology from Chirayu Hospital, Kalburgi. So it's really lovely to have all three of you in this expert panel, and we really hope to have a very interesting discussion today. So think of an orchestra where every musician is really perfect in what they do. They are exceptional. The pianist knows what they are doing. The percussionist is very precise in their notes. The violinist is flawless, but there is no conductor between the three of them. Right? So what happens is each of them are playing their part beautifully, but the notes are not the same. And therefore what we get, the music we get is not symphony, but cacophony. Chronic metabolic diseases, when we look at it from, sitting in our specialty clinics, from an endocrinology clinic or a cardiology clinic, we play isolated parts of an orchestra, not in sync. We end up getting that cacophony instead of the symphony, wherein each of us is doing their jobs perfectly, but the synchronization is lacking. So that's the real crux of what we'll discuss today, because I think when it comes to chronic metabolic disease, we really need to have that symphony among ourselves, the synchronization among ourselves. I think the cardiologists do a fabulous job in treating cardiovascular disease or CHF. The nephrologist is doing their bit beautifully, and the endocrinologist manages diabetes, obesity, all well. But somehow our patients carry so many myths, misconceptions related to obesity, diabetes, and cardiovascular disease. As an endocrinologist, I can say patients come to me and say, our diabetes is not controlled. You just focus on the sugars. The rest the cardiologist is doing. But somewhere I think that synchronization is needed. So I'll begin with Dr. Santosh. The first question, is it time now we strongly consider obesity as a chronic disease, or we just say it's a lifestyle problem? What's your take on that?
Thank you so much, ma'am, for having me on this. And definitely, now from lifestyle disease, as you rightly mentioned, it is moved on to a disease particular, because we've seen the overall prevalence in whole India. It's almost to the tune of 25%, and we have seen how it is gone high. Like even I was shocked at the stats when I was going through this stats today. I was shocked to see that from 1990 to 2022. It has almost doubled. It has almost doubled in the adults, and it is quadrupled in adolescents. So it's like a time bomb kicking in. And when I was going through the economic aspects of it, I was just going through economic aspects of it. So the cost of treating obesity-related comorbidities, it is almost equivalent to. They have shown that it is 1% of GDP.
Oh,
1% of GDP. So all health-related costs. So, and in 2030, it is projected to be around 2.5% of GDP.
True.
So I think this is the right time where with new drugs coming in, I think it has to be labeled as a disease, and and majority it has to be some amount of awareness. There is some amount of gap between awareness between the urban and the rural health. So we have to hit hard at the primordial level, not at the when the patient coming. We have to take care of the pregnant women, the children when they're class. Some awareness has to be done at that level only. This is my take on this particular question.
True. I think very rightly pointed out that it's a problem that's going to cost us hugely across along as the years go forward. The cost of treating it now and preventing it now probably will be much less than the cost of treating the complications, let's say a decade down the line, both individual cost and the cost to the nation. And like you said, prevention, I think, is the strategy that we really need to hammer, especially in children and adolescents. So prevention is the key here. But Dr. Santosh, another question for you. Obesity is defined by body mass index. We've been using those cutoffs for now, I think, decades and decades. But somebody with a BMI of 35 versus somebody with a BMI of 27, you might have the 27 BMI person more unhealthy when coming from a metabolic perspective. So do you think we should change now from using BMI to actually using the staging system like the Edmonton Obesity staging system, or what the Endocrine Society also suggests, the ABCD, adiposity-based chronic disease classification?
Okay. So a lot of times the traditional teaching is that we try to define obesity depending on the body mass index. But I think we should somehow change it in this perspective, because in our continent, where we see South Asian continent, where we see a person with normal BMI, but the fat distribution is completely different.
Yeah.
So I believe that we have to look at more aspect of fat distribution rather than BMI. So because that is the visceral fat distribution is the main harbinger of all the. You right now you said about it is the front runner of all the complications. So I believe so somehow we have to concentrate at the fat distribution rather than BMI. Is what my take.
Yeah. So what you're saying is actually, even if you're not doing a body fat percentage, markers like waist circumference, they come in as a actual marker of bad metabolic health. And like I was also talking about, Edmonton Obesity staging system that was given by Canada, or the ABCD system that has been proposed by Endocrine Society of US. We should look at comorbidities that are coming with obesity. And more the number of comorbidities, more the urgency to treat it as a disease. So coming to you, Dr. Shankara.
Yes.
Now, we have been talking so much about heart failure, right? The last decade, with SGLT2 inhibitors, heart failure has become the talk of the town. We talk less cardiovascular disease, we talk more about heart failure. But do you think obesity has created a phenotype of heart failure which we were not seeing before? Like in my MD, we never talked of these kind of heart failure conditions.
Yes.
He talked of diabetic cardiomyopathy as some kind of a mysterious illness. But now we know heart failure is the leading cause in diabetes of morbidity and mortality. So what is your take on that?
Definitely, ma'am. This actually, there's so many investigations which are helping us to recognize those patients very early. This obesity-related cardiomyopathy, which is called obesity cardiomyopathy, this is the new terminology which we are using. And any patient who has BMI, for Indian, we take more than 27 as obesity, madam. So if we we can use waist circumference 90 for men, 100 for women. So that we can use to classify as obesity. And me and Santosh, we work in same hospital, and he always sends me case that okay, she needs some echo, please do the echo, and invariably she will be in heart failure. And this is most of the time it is heart failure with preserved EF. And we routinely do internal pro-BNP that gives us early recognition of heart failure also. So most of the time it is preserved EF. That is what we see in obesity related cardiomyopathy. And with the available of new medications, it is completely reversible. And even we can completely eliminate with reducing weight also. So definitely it is a new entity, and it is right time for physician to recognize. As a cardiologist, we know we are already diagnosing them. I think the physician should identify those cases and send to cardiologist. And if we treat early, we can prevent further means ultimately it is the economy of the India which is affected because of the large population of the patients. So I feel I was also going through literature today. I was shocked to see so many things. There are so many things happening in obesity. I think it is right time we should wake up and we should teach our colleagues about all the problems, not just cardiomyopathy. There are so many things from cardiac perspective in relation to obesity.
Yeah, very true. So in that regard, I'll also extend this question. Do you think the risk of arrhythmias, especially AF or sudden cardiac death, is more in people with obesity?
Yes, ma'am. The problem with obesity is it not only increases the preload, afterload, and even though there is a link, cardiorenal link is also there, it increases the volume also. So these things relate to increased LV and diastolic pressure, and it further stretches the atrium. This is one mechanism of atrial fibrillation, and another is this infiltration of the fat into the atria. That will also trigger atrial fibrillation. So this is one mechanism. Another is these people are more prone for obstructive sleep apnea, and that can cause sudden cardiac death in the night. And we do a lot of sleep study in our clinic. I think all the patients will come under high risk of this OSA. All the majority, and the means we are just doing hand picking the cases, and all of them are falling in OSA category. So means the risk of sudden cardiac death is very high, and it is not recognized by anyone. That is the most important problem. As your first question was, is it a disease? Definitely it is a disease, and we have to be very active in managing that disease.
True. Completely agree. I think what I learned from your message and what the message is for the audience here, that people with obesity, when they start complaining of shortness of breath or fatigue, don't just think it's weight related. There could be a cardiac issue, and get a good
people rule it as a deconditioning, and they may fail to recognize it as a obesity cardiomyopathy.
Yeah. In fact, the general public also thinks this person has excess body weight, so the shortness of breath is bound to happen. But actually, there's a disease underlying it. So, Dr. Purnima, coming from the cardiology perspective, so we talk of obesity and diabetes, and we talk of chronic kidney disease. We've moved away from that traditional concept that only hyperglycemia, like it happens in type 1, that hyperglycemia leads to kidney disease. We now are seeing an entire new spectrum of disease wherein sometimes albuminuria is present even before diabetes, or a person with diabetes has CKD even in the absence of albuminuria. So how important do you think is the relationship of obesity per se with CKD?
Thank you, madam, for having me here. Coming to your question, diabetes and hypertension have always been one of the leading causes of CKD. And in diabetic type 1 and type 2 diabetes, usually type 1 diabetes is after detection, not necessary that they may have CKD at the point of detection of type 1 diabetes. They develop much later on. We tell them to monitor for albuminuria, serum creatinine. But in type 2 diabetes, maybe it is because type 2 diabetes goes undetected for a longer time. But at the time of detection itself, it is necessary to check for serum creatinine, diabetic retinopathy, and for albuminuria, because most of them would be having it at that point itself. But microalbuminuria might be persistent even in pre-diabetic patients or in patients who are not yet detected with diabetes. That might be because of other causes like hypertension or obesity, which might lead to glomerular hyperfiltration and glomerular hypertension, which leads to microalbuminuria. And they are susceptible for developing pre-diabetes and diabetes on a later date. And the second part of the question, madam,
it was with relation to non-proteinuric DKDs, like the non-proteinuria variants that we see very commonly now. Without proteinuria, there is DKD there.
Yes, we can find DKD in patients even without microalbuminuria. In such patients, we usually look for other signs like serum creatinine and also for retinopathy, because in patients with type 2 diabetes, there is 90% concordance with retinopathy. So that's an indirect indication of saying that the patient might be having diabetic nephropathy. So that is how even the guidelines, they say that once the patient is detected with diabetes, we check for microalbuminuria, serum creatinine, and for retinopathy. And we usually don't do biopsy in patients with diabetes, because these are the indirect markers of saying that the patient has diabetic nephropathy. Only when the patient doesn't have retinopathy, microalbuminuria, that is when we think that the patient might be having something else, and we look for other causes. But because of the like you have mentioned, because of obesity, hypertension, and other lifestyle changes and other comorbidities, non-proteinuric CKD is common, and among diabetic and non-diabetic patients.
True. So what I get, and I think the message to the audience is, look for chronic kidney disease evidence.
I'm not able to hear you, ma'am.
Yeah. Okay. So I think what we can infer here is that we look for the evidence of chronic kidney disease, even in the even when diabetes has just begun, or even in pre-diabetes stage, you can actually have some changes. So we should do a GFR assessment and albuminuria assessment right in the beginning. I think we have lost. Okay. So Dr. Shankar, you were talking about sleep apnea, and sleep apnea and obesity, I think they're villains in partner. They walk together. We know that it's not just obstructive sleep apnea. There is also an element of central sleep apnea. I think Dr. Santosh will tell us that better. But we do see a strong element of central as well as obstructive sleep apnea in people with obesity. When it comes to cardiovascular consequences, like we know sleep apnea will increase insulin resistance, it contributes to worsening of diabetes, there is sleep fragmentation, hypoxia. But what are the other consequences, particularly from cardiovascular side? Do you think it adds to the burden of hypertension, or is it a cause of resistant hypertension and heart failure as well?
Yes, madam, definitely. This obstructive sleep apnea, one, it can cause sudden cardiac death. And the second, the chronic obstructive sleep apnea can lead to elevated right ventricular systolic pressure. It can lead to right heart failure and severe pH also. Many times patient is referred for evaluation of pedal edema, and they initially we diagnose it as right heart failure, and we end up diagnosing as obstructive sleep apnea, which is the primary etiology for all these symptoms.
Okay.
And second is, as we said, arrhythmias. And this sleep fragmentation definitely can cause resistant hypertension in few patients. And the one issue with sleep, this hypertension and obesity is we should target sympathetic activity. Majority people, they put on other drugs, and that is where beta blocker is indicated. That is where it acts on renal nerves, and it acts both reduces sympathetic activity as well as effect on RAS blockade also. And that is the primary mechanism of hypertension in obesity. So I think that is where if we add beta blocker, we can control hypertension. And in majority of obesity hypertension patient, my first choice is bisoprolol. I usually use bisoprolol to control, and it acts very nicely, and it controls blood pressure also.
Yeah. I think that's a very important observation, because a lot of these patients will have sleep fragmentation, hypoxia, or episodes, and the sympathetic nervous overactivity is actually significant. And that's also one of the reasons I think a lot of these patients have resting tachycardia when we see like
Yes,
pulse
yes, yes.
rates,
That is another indication for beta blocker.
beta blockers. So
That is
we
a
are
sign
probably
of sleep overactivity.
Dr. Purnima, back to you. We were
Yes,
talking
ma'am.
about albuminuria. We know
Yes.
diabetes is a risk factor, hypertension is a risk factor. What are the other risk factors for albuminuria, which can be modifiable? What we can tell our patients that this is what you can do to reduce albuminuria.
Madam, modifiable risk factors are lifestyle, mainly diet, lifestyle changes like avoiding smoking, alcohol, because even they are known to cause albuminuria. Long-standing smoking and alcohol causes oxidative stress, chronic inflammation, and they can cause proteinuria. And lifestyle changes, due to in today's time we see that. There is, like sir mentioned, increased incidence of obesity. So obesity also leads to a glomerular hyperfiltration, increased glomerular hypertension, and microalbuminuria progressing to macroalbuminuria. So that is also a modifiable risk factor. And hypertension, then diabetes uh, are some of the modifiable risk factors which we should take into consideration.
Yeah. So when talking about, let's say, change, what strategies to reduce albuminuria or manage the risk of albuminuria, how about nutrition? Now, in obesity, a paradox will emerge. A lot of general population has this idea, I'm having albuminuria, I should cut back my protein intake. But from the obesity perspective, I actually want my patient to optimize the protein intake so that when they're doing weight loss, muscle loss does not happen. So, as a nephrologist, what is your message? Let's say this EGFR is normal, there is albuminuria. How much protein would you optimize?
How much?
Protein intake would you recommend without any reduction in GFR? They're having albuminuria? Would you actually recommend a higher than normal protein intake? Normal protein intake?
Madam, it depends on the stage of CKD. Usually stage 1 and stage 2 CKD, we don't advise any protein restriction. Only in stage 3, stage 4, we tell them to take a normal protein and avoid animal protein. And in stage 5 CKD, when after the patient has been initiated, in fact, we ask them to take a high protein. We, in fact, sometimes advise protein powders. We ask them to take egg per day, because once we start dialysis, patient will again lose muscle mass, because during each dialysis they are going to lose 6 to 8 grams of protein, and even if they're, be it hemodialysis or peritoneal dialysis. So we advise them to take a high protein diet once we have initiated them on dialysis. Protein restriction is only for the later stages of CKD before they are initiated on dialysis. And like you mentioned, there is something called as reverse epidemiology. That is, obese patients, when we have initiated on dialysis, that obesity actually acts as a protective mechanism for them, because there is a nutritional reserve, muscle reserve for them. So in the initial time of dialysis, that obesity, actually what we call it as obesity paradox in nephrology. So in the initial time, that actually is seen as a protective mechanism during the initial few days of dialysis.
That's actually a very interesting concept. I actually never heard about this obesity paradox, but yeah, that's very interesting. So, Dr. Santosh, talking from endocrine perspective, does hyperglycemia drive the complications once insulin resistance is there, or does insulin resistance has its own problems before even hyperglycemia has emerged?
Okay, so whenever we're talking about obesity, we always insulin resistance goes hand in hand. So once there is increase in insulin, once there is increase, this is the major culprit driving most of the complications of diabetes. That is activation of SNS, it may be, or there may be increased absorption of sodium from the tubules, increased volume, or activation of LH axis in the female causing hyperandrogenemia. So everything. So insulin. There is differential insulin resistance. There is hepatic insulin resistance. There is peripheral insulin resistance, and this hepatic insulin resistance itself causes increase in hepatic glucose output. At the peripheral level, causes increase in free fatty acids, thus causing lipotoxicity, thus attacking the pancreatic beta cells more. So I always believe that first it is hyperinsulinemia causing the main culprit and attacking most of the complications. So trying to hitting hard at this one pathophysiological issue will try to address most of the complications. So it's hyperinsulinemia affecting most of the complications.
Yeah. So insulin resistance actually is, driving a lot of issues even without, in the absence of high glucose value. Let's say system-wise, obesity complications. I think we've been kind of looking at that one diagram of
Yes.
complications of obesity right from our MBBS and MD days. Dr. Santosh, would you like to recapitulate what all can go wrong in a person with obesity?
Okay, basically, we all know that adipose tissue itself acts as an endocrine organ. So, releasing a lot of hormones, especially there is leptin, adiponectin, and a lot of inflammatory markers. And this everything, this whole milieu is set in the blood system. And thus, first, whenever I see a patient coming and walking in, we should see in toto, not attacking the glucose levels. Try to see in toto. That's first. I would like to see the part affecting the liver, that is the fatty liver component. Fatty liver, whether easy progressing to NASH. The one we all know that now the most common cause of one of the liver cirrhosis is obesity, is the NASH. So first affecting the NASH, and then when we look at GI perspective, first is the liver, then the GERD. We see a lot of symptoms. GERD patients are just walking in GERD. They are popping up a lot of pills. So with some weight reduction, they are already rid of this GERD. And I would not like to go into the cardiac aspects and approach because they already spoken about those things. And OSA part also spoken. One thing which is not spoken is about the reproductive system, where reproductive system in males and females. In males, we see some amount of hypogonadism, taking in hypogonadism, loss of testosterone, loss of libido. And in females, the other end, it is the opposite. There is hyperandrogenemia, thus causing PCOS and most major cause of infertility. Now we see the infertility boom. Infertility boom is happening here, and a lot of therapies. So I think addressing one issue of obesity will treat most of the issues. So I think I have covered about reproductive system, GI, and one more is some aspect of even obese patients. When I see obese patients, some kind of psychological issues with them, with their some amount of depression going in. So I think they also need to meet a counselors, like at least they have some low self-esteem. When I see those patients where the BMI is 35-40, they never think that it is a problem itself. So I think one consultation with them will also address most of these issues.
Yeah, rightly pointed out. I think mental health challenges are a very, very important aspect of obesity. And you have those extreme of patients. There are young, I see a lot of young girls or young boys who are extremely worried about a BMI of 25 plus because of that body image issue. And then there's the other extreme that you spoke about, BMI of 40, they don't care because they're doing well. But yeah, there is a huge burden. For the audience, I think I'll try to recapitulate what Dr. Santosh said. all of the complications of diabetes, we could call them as 4 M's. That's the way I remember them. M 4 times. So it is metabolic, it is mechanical, mental, and the fourth I like to add is malignancy, because we often forget that malignancy rates are actually higher in people with obesity. Whether it is breast cancer, pancreatic cancer, GI cancers, the risk actually is higher. Ovarian cancer, endometrial cancer, all of these actually increase. So the metabolic we've been discussing. So it's diabetes, hypertension, cardiovascular disease, CHF, CKD, MASLD, all of these are metabolic complications, along with PCOS. That's what Dr. Santosh was describing, and kind of hypogonadism, a functional hypogonadism in men. Unfortunately, actually, all of these improve when you lose a quantum of weight. Then mechanical, you could have, spinal problem. You could have obstructive sleep apnea. You could have Blount's disease in the knees, or knee osteoarthritis or hip osteoarthritis. Again, all of these complications are pretty common. And mental, a higher rate of depression, anxiety, binge eating disorder, in fact, is very common in people with obesity, or not exactly frank binge eating, but disordered eating patterns are, I think, seen in almost 70% of people who have, adiposity-related disorders. And suicidal ideation also actually tends to be more, and it creates a tricky situation when it comes to anti-obesity medications, especially when mental health challenges are already in the running, and then malignancy we've talked about. So the next round of questions, Dr. Purnima, talking of now medication. So people with CKD or at risk of CKD, what are the drugs you would want to see in the prescription, in your prescription for kidney protection?
Madam, yeah. So, be it obesity, be it hypertension, or be it diabetes, kidney protection starts with what is the cause of the CKD. So, if it is so the underlying cause is hypertension, CKD, and obesity, we have to control it. So, even the guidelines say in CKD the BP has to be less than 130/80. And the first line of medications according to guidelines is also ACE/ARBs, RAS inhibition, because again RAS inhibition reduces the glomerular tension and reduces albuminuria. And the second line of drugs, not only for CKD, even for diabetic CKD, are SGLT2 inhibitors, which the new KDIGO guidelines also mention, because again by SGLT2 inhibitors reduces by causing glycosuria. One, it causes apparent arteriolar dilatation, and so there is decrease in glomerular hypertension. And second, by its diuretic and natriuretic effect, it reduces sodium and water retention. Third, by it reduces inflammation. Fourth, it reduces interstitial fibrosis. So, and fifth, because by reducing weight, reducing obesity, it has an indirect effect again on the kidneys. So, second line of drugs, again, SGLT2 inhibitors if the patient is diabetic. And third, in diabetic CKD, again, GLP-1 analogs. But again, depending on the GFR, be it SGLT2 or the GLP analogs, because we cannot use SGLT2 in GFR less than 20. The only OHA we can use even in GFR less than 20 is linagliptin, which we have been using for both cardioprotective benefit and as well as for control of blood sugars. And other drugs which I would want to see in the prescriptions are maybe in the current guidelines also mention about finrenone. So maybe that in CKD and diabetic CKD, it has proven to be beneficial in reducing microalbuminuria and reducing the progression of CKD.
So, out of all of these, where do you see the place of, let's say, the GLP-1 receptor agonists and particularly weight loss? Like, do you think that helps improve kidney health if patient is reducing weight?
Madam, one, yes, because GLP-1 analogs, by reducing by controlling sugar itself, it helps reduce the progression of CKD. Because in diabetics, in controlled diabetics, there is still loss of GFR at a rate of 4 to 6 ml per year. And in uncontrolled diabetics, the loss of GFR is up to 10 to 12 per year. So GLP-1, by controlling the blood sugars, indirectly helps in reducing the progression of CKD. And second, by reducing weight, obesity, indirectly again it helps in slowing the progression of CKD. And third, there is another proven pathway that it inhibits the TGF beta pathway, in which so it reduces the tubular interstitial fibrosis, and it reduces the progression of CKD. These are some of the methods in which it will help, be it direct or indirect.
True. I think now we do have outcome data also with the recent flow trial and the previous trial with dulaglutide, that it does help reduce the progression of CKD, and in people with CKD it also helps in reducing MACE events and cardiovascular outcomes become better. So
all leader, sustain and flow trials all have shown that GLP-1 analogs have shown to reduce microalbuminuria and slow the progression of CKD.
Dr. Shankar, from your perspective, from cardiology perspective, how important is weight reduction? And where do you see the role of the newer, anti-obesity medications or anti-diabetes medications with weight loss properties, like GLP-1RA or pipeline drugs in that range?
My first choice will be GLP-1 analog and SGLT2 inhibitor. I think I am the only cardiologist in Gulbarga who is writing GLP analogs, except it is usually prescribed by endocrinologist. But because I work with endocrinologist and I know the importance of losing weight, my first prescription post ACS also, post stunting also, we are very aggressive. Both of us, we are very aggressive in obesity individuals. Many of the patients, especially the patient with hypertension and obesity, many of them have stopped the anti-hypertensive medicine after losing the weight. So our first target is weight. Afterwards, we'll give the treatment for complications. So in all of the prescription, I will write SGLT2 inhibitor because it has shown beneficial in heart failure with preserved EF. It has shown reduction in weight also, and this GLP analog ones, there is still hesitancy among the patients, especially healthy patients who don't have any complications. They are still hesitant, but those who have suffered complications like acute myocardial infarction or admission for an heart failure, those are they accept the drug very quickly, and they do remarkably well when we start those medicines. And so my first choice will be anti-obesity medicine. After that, I treat my cardiac cases or cardiac complications.
So it seems like between Dr. Shankara and Dr. Santosh, there is a Jugalbandi already in place.
Yeah, we are learning and it is helping patients.
So there's already a symphony there.
Yeah.
So coming to Dr. Santosh, so when we talk of the GLP-1RA kind of drugs, or the dual agonists now, and then we have triple agonists coming in soon. What do you see the role of these drugs? Is it just for glucose control or weight loss benefits? Or when you talk to your patients, how do you convince them to take what you say?
Usually when I see in my OPD, there are two types of patients as we see. One type are those who are hooked into social media and they are seeing this lot of obesity drugs. And they've seen recently there was a price reduction, some 37% of a price reduction of Wegovy. So with price reduction, a lot of people, they just come and they barge into the OPD and ask, give me a prescription. There's one chunk of patients telling, give me a prescription. Yeah. So and the other chunk of population who really needs it, they are talking about what are the associated side effects. Does my kidney damages to this long term by taking these molecules. So it's completely apart. So one patient coming in and one patient telling no, even those patients who are needed, they just try to avoid it. So first and foremost, for both all this for both these patients, I counsel them about, first and foremost is about the diet. The most important, you should put them on a, I never give them even it is a hard indication. So for the first month, I never write any of the molecules, because first month I want them to be on a low calorie diet. Low calorie diet. They have 2 calorie counting, and then the next month they'll come into the clinic. They are already primed up. Okay, primed up. And then and the second time when you add this molecule, whichever you're talking, it can be a GLP-1 RA or dual agonist. Started slowly tell them what are the accepted side effects. These side effects are there with any of the molecules. I try to compare them. In my side, it might seem very jocular. I tell them, like, you go to a stall and you have 1 plate of pani puri and you tend to eat 3 to 4 pani puris, 4 plate pani puri. You ultimately have some sort of side effects. You have gastric burning. So I tell the same side effect. First you will experience for a few days the same side effect. We'll build up with the low dose of this molecule, and then weekly or monthly on basis we'll try to step up this. When I'm stepping up, you'll always find some amount of weight loss. But at some amount of time, you have to put your own efforts. Like there has to be some amount of exercise going on. I never tell them to exercise on same particular day, because when they're trying to exercise, they come back home, they're hungry, they eat again. So there is no particular weight loss. So first I try to cut down the calories, maintain that carbohydrate content in that individual, and after next month I tell about some amount of exercise. So first is diet, medication, exercise, and the third and the most important thing for us to have a sustained effect is the behavioral change. They have to have a behavioral change, because at one point of time we all know that these drugs are going to, there is some amount of weight gain happening when you stop these medicines. So at that time, the behavior change, when these people have learned, when these molecules are there with them, like I try to ask them not to have dinner, skip dinner, or low carb dinner. So such type of behavioral change will have a sustained weight loss in them. To have sustained weight loss, we have to have diet, molecules, exercise, and then a behavioral change. This is what I tell them at my, it requires many follow-ups. Not in one follow-up is very difficult. In subsequent follow-ups, we can tell them this.
True.
And other part, I tell them what are benefits. Even if you lose, I give them a target weight loss. We are not going to have a sudden. I'll just give even 7 to 10% of weight loss. Some amount of motivation. We see the number of diabetic medicines coming down. We see antibiotics coming down. There is also a sense of well-being. So all these things brings a some amount of motivation and a behavior change. So this is what I try to do it.
Yeah. So I think counseling, the very basics of obesity care will always remain in lifestyle modification, and medications support that lifestyle modification. Plus, of course, they have their pleiotropic benefits. So GLP-1 RAs, we know as a class, they have cardioprotective properties which occur beyond weight loss. So the SELECT trial actually has shown CV risk reduction occurs before significant weight loss has happened. So that's important. And then we have data for MASLD, we have data for CKD now, and work is ongoing. We have some data building up for sleep apnea as well. And very interesting work going on in Alzheimer's disease, another mental health disease which is being linked strongly now to obesity. So I think we've had a very, very interesting discussion overall. We've gone all over the discussion, and probably we've created a symphony of our own, I hope so. But one concluding remark from all of you, maybe we'll begin with Dr. Purnima. Any message for the audience?
Madam, nephrology has never been an isolated department. We always have been get involved with other departments, be it pulmorenal, cardiorenal, or now obesity renal. So I think it's high time we all start looking at a patient in a holistic way and have a holistic approach towards any disease, and not just looking at a particular parameter or a particular organ. So based on current lifestyle and current way the diseases are progressing and the diseases are showing up at an early age, it is very important to start screening patients from an early age, and also, like sir mentioned, bring a behavioral change, because always prevention is better than cure. And along with that, it's very important to detect the diseases early, uh, be it any lifestyle, be it diabetes, hypertension related or obesity related. Detect it early so that we can intervene early. And we need to have an holistic approach in today's world, so that we can have a better follow-up of patients and better treatment of patients.
True. Very true. I think the message is loud and clear. We are not islands unto ourselves. We work together better as a team. And as you rightly pointed out, in fact, my best friend happens to be a nephrologist in the city. So we've been like almost now 19, 20 years together. So Dr. Santosh, your comments?
Okay, so my only one liner will be, first, create awareness about this silent pandemic in terms of the disease, in terms of the treatment options, and also in terms of remission, which are they are going to have in most of the complications, remissions of those complications. So the first is only thing is the first step, because there is still a very long way to go. There is very long way to go. So my only at this point will be creating awareness among the public. This is only one line will be the creating awareness.
We really need to, tackle whatever myths and misconceptions are going on in the public domain. And the social media actually is helping us, but also hurting us in that regard. But we need to go a step further. Dr. Shankar, what would be your message?
I think it is the right time. We should recognize obesity as a proper disease. We should recognize the complications. There are medicines available. Disease is reversible. I think with the arrival of GLP-1 receptor analogs, we are more equipped to treat the disease. I think the patient should what everybody was saying, that there should be awareness among the patients that it is a disease, and it should be a holistic approach. What even I was telling was, at the end of the para, you should include your nephrology and endocrinology friends when you are treating obesity related cardiac complications, and also a referral to nutritionist.
So nutritionist and a support team is very, very integral to our care. So I think we've had an excellent discussion. At the end of the day, I'll conclude by saying that we have to start looking at obesity as a chronic, progressive, relapsing disease, not even a disorder anymore. We really need to change the framework here. And, what happens is, when we call it a lifestyle problem, we put the onus on one person to correct, and the person who's actually suffering from it, we put the onus on them that, look, you are not eating right, you are not doing this, you are not doing that. We need to step back and see why it is happening, what it is causing, because there's a whole bunch of complications that are coming with it. And then we really need to assist that person who is dealing with those complications. While, of course, yes, the bigger picture, the bigger scenario would be prevention. And for that, we'll have to do something about the obesogenic environment around us. But we cannot blame a person for getting obesity or having a disease. We cannot blame anybody for having diabetes. We cannot blame anybody for having heart disease. The same way that blaming has to go, and we need to help and act together. So thank you so much for a really pleasant session. I hope the audience has had a good time, and we'll see you yet for another episode. Thank you.
Thank you.
Thank
Thank you so much.
Thank you. Thank you.